Good morning, everyone, and welcome to the Patients for Safer Nuclear Medicine webinar on extravasations in nuclear medicine, what you need to know. So we're going to start out this morning just defining nuclear medicine. So to see inside your body, your doctor might prescribe a nuclear medicine scan. Unlike an X-ray or CT scan, a nuclear medicine scan requires nuclear medicine. Nuclear medicine combines a radioactive isotope with a carrier drug, which is injected into your vein prior to the scan. The nuclear isotope passes through your body and is picked up by the PET or SPECT camera. The resulting image of a nuclear medicine scan will show the inside of your body lit up, which allows the doctor to diagnose and determine treatment based on the image. When these scans are done correctly, the amount of radiation emitted to the patient is safe. And what I just described to you is a typical nuclear medicine scan. An extravasation is a medical error that can occur during these scans. An extravasation occurs when the person administering the radioactive isotope misses the vein and the isotope is injected into your tissue. If this is a large extravasation, that radiation is now concentrated in your tissue and is not flowing throughout your body like it's supposed to be. These large extravasations can now be harmful to the patient and can lead to long-term tissue damage further down the road. Additionally, since that isotope did not flow throughout your body, the resulting image can be inaccurate. But no one will know it's inaccurate because at this time, institutions are not required to monitor or report extravasations. So nobody at your institution will know when a large extravasation occurs, yet they're basing their decisions on some of these inaccurate images. An inaccurate image can lead to misdiagnosis. It can lead to incorrect staging of disease and the wrong treatment plan. So let's take a look at an extravasated image versus a non-extravasated image. As I mentioned, one implication of a large extravasation is that the images can become inaccurate. These two images are of the same patient. You will see the extravasated image. This patient was clearly extravasated, as you can see in the arm. The image still comes out, but as I mentioned before, because the isotope is so concentrated in the arm, the entire amount didn't flow throughout the body. So the physician determined the prognosis of this patient was good after 3 to 4 months of treatment. They picked up a lung lesion, but no other disease was noted. Luckily, this particular institution and this particular physician wanted to re-image this patient. Just a reminder to please shut your video off until the presentation is over. So this physician re-imaged this patient 3 days later. You can clearly see there's no extravasation. You can note the differences in these images of an extravasation versus non-extravasation. Look how different these two images are. The lung lesion was still noted, but it's 80% more active than the first image. More importantly, metastatic disease was picked up in the non-extravasated image, but was not picked up at all in the extravasated image. This is two very different prognoses for the exact same patient, all because of a large extravasation. This patient, the second image, the prognosis was not good, and this particular patient actually passed away 5 months later from his disease. That's a lot different from the first image where he was given a good prognosis after 4 months of treatment. So how often, here's another implication, as we mentioned, is the damage to the tissue. Large extravasations have led to secondary cancer development, as you can see in this picture of this hand. It can also lead to skin necrosis, which may require skin grafting. These are just some of the complications that can happen from a large extravasation. So how often do extravasations happen? There are around 30 million nuclear medicine injections a year. This is an estimated in the United States. Of those 30 million, 4.5 million are extravasated. Of those, 500,000 are large extravasations, where patients can be harmed, there can be tissue to the damage, and there are inaccurate images due to the large extravasation. This can come out to approximately $3 billion in healthcare waste annually. Just think of the patient I mentioned previously, where if he was not re-imaged, he would have spent 3 to 4 months of costly treatment for a cancer that had already metastasized. And that's happening to 500,000 patients estimated in the US every year. So why is this happening? Because extravasations at this time are not considered a reportable medical event. There has never been a requirement to report these large extravasations. Why aren't they reported is probably the question you're asking yourself. The Nuclear Regulatory Commission, known as the NRC, is responsible for the proper use of these radioactive isotopes in medicine. Due to an incorrect NRC policy created in 1980, there are no reporting requirements for accidental radiation exposures to a patient's skin or tissue as the result of a large extravasation. Yet, if that same medicine was spilled on your skin, it is reportable. But when that medicine is accidentally injected into your tissue instead of your vein, it is not reportable. So the Patients for Safer Nuclear Medicine Coalition submitted an information correction request asking the NRC to correct this wrong policy. Because most extravasations can be prevented with proper training and tools. But this won't happen unless the NRC makes extravasations reportable medical events. As a coalition, we are not advocating for getting rid of nuclear medicine scans. We are advocating for making these scans safer and more transparent. And now I'd like you to hear from a patient who actually experienced an extravasation. Pam Cole is a metastatic breast cancer patient who depends on the accuracy of her nuclear medicine scans. And during a recent scan, she was extravasated. As you can see, this is Pam's actual film from her, and you can see an extravasation is clearly in her arm. So I'd like to introduce you to Pam now to tell her story.
Thank you so much. That was such a great summary of what this whole issue and topic is about. So thank you. That was great. So I'm Pam Cole, and I have been living with stage 4 metastatic breast cancer for 5.5 years, which is great. Only about 28% of those of us living with metastatic breast cancer hit that 5-year mark. And one of the ways that we hit that 5-year mark is through our scans, and we get scanned every 3 months. And this is critically important because we will be in treatment the rest of our lives, and our drugs fail. You know, they do great for a while, and then that drug fails, and we have to go on another drug, et cetera, et cetera. all of those treatment decisions are based on the 3-month scans. So if I have a scan and my current tumors, or METs as we call them, grow, and or if I have new METs, then we know that my treatment is starting to fail and we need to rethink what we're doing. So that's why this is so important. And I was going in for my 3-month scan, and I get at 3 months, I get blood work done, I get a CT scan, and I get a bone scan. The bone scan is critically important. Estrogen positive breast cancer, metastatic breast cancer tends to go to the bone. So it's very important that that bone scan is accurate. And as the technician was putting the nuclear medicine in my arm, I could feel something burning. I get these every 3 months, again, for 5 years. So I'm pretty familiar with what this is supposed to feel like. And I knew something wasn't quite right. It wasn't that it got swollen, but it just didn't feel right. And I kept saying something to the technician, that this is not, something is wrong. And she just was sort of, no, everything's fine. It flushed, blah, 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 you know, all the language of scans. But I knew a bit about extravasation. So I was adamant that I wanted her to check. And finally, she agreed to take me down the hall to a machine and she would put my arm in the machine. I need to step back a minute and say that for most of these scans, my arms are not in the scan. My arms are up over my head and are not in the field. So if we had gone ahead and had the scan, they still would not have seen the extravasation at that point because my arm would not have been in the field. So when she looked, she saw that there was an extravasation. And she did nothing to mitigate any kind of damage. She did not do any kind of massage or warm compresses. And everybody agreed that I should go ahead and have the bone scan. You know, I am a very fierce advocate and have been for quite a long time. But when you're in your robe at the gown and meeting with doctors, and your life is sort of in their hand, and you trust your medical providers, even someone like me who knows about extravasation and is a fierce advocate, sort of cowers. And so I said, okay, let's go ahead and do the scan. And you know, I also thought to myself, well, I'm going to get scanned in 3 months anyway. So they did the scan, and we will never know whether that scan was accurate or not, because we didn't do a second scan later, a few days later after the extravasation. And the problem is that we absolutely know that these extravasations are preventable. With retraining and quality control, they are preventable. Technicians need to be retrained if they know that they're extravasating. And I need to know which hospital and which center is doing a good job with extravasation and has protocol about this, and which centers don't. And all patients need to know that. Many, many years ago, mammogram machines were not calibrated on a regular basis. And it was based on strong advocacy from the breast cancer community that we were able to get rules and regulations changed so that mammography centers are reviewed, and publications of their ratings are now available. And if they find that there are enough mammograms that are incorrectly read or incorrectly seen, they'll send letters to the patients who have had mammograms there to have them come in and get second mammograms. That was only done because active advocates made that happen. And that's what we need to do now. We need to have this reportable so that the institutions themselves understand their level of extravasations and what kinds of training and quality controls they need to set as a standard of care for nuclear medicine, number one. Number two, the patients need to know that they've been extravasated, and they need to be, it needs to be explained whether they need to have another scan and or what they need to be looking for in terms of damage to the tissue. And the technicians need to know so that they can learn and be trained and understand the implication of these kinds of testing. Again, this is preventable. And we really have no idea how often this happens and in what kind of setting and where these happen. So it's not okay in any way that we are getting scanned as an initial diagnosis that may be missed, or those of us who are depending on these extravasations for deciding our treatment. And the fact that if a little tiny drop of the nuclear medicine dropped on my skin, it would be reported in all of those ways. But if it gets out of my vein into my tissue, it doesn't get reported, is absolutely absurd and not a healthy situation for me, and not a positive way for an institution to do better. And we all need for these kinds of tests to be better and accurate and transparent.
Thank you, Pam. Well said. Well said. Please save your questions. Pam will be on during the entire call. So if you have questions for Pam after the presentation, she'll be happy to answer them. So just building on what Pam had just said, the Patients for Safer Nuclear Medicine Coalition was really established to encourage this NRC, Nuclear Regulatory Commission, to change the reporting requirement and make nuclear scans safer. Again, we believe nuclear medicine scans are needed. We just want them to be safer, more transparent, and effective. We don't want to go in for our scans like Pam did and not know if that image, the resulting image, is inaccurate because of an extravasation. So currently we have 29 patient advocacy organizations as members of the coalition, 5 corporate partners, and we're growing every week. We are dedicated to the development of these federal policies that support safe, transparent, and effective nuclear medicine care. So what have we been doing? In the last year, we sent 620 signatures and a correction request to the NRC, asking them to correct their incorrect policy from 1980. We've been writing letters to the NRC commissioners. We reached out to payers and members of Congress. We've published media articles, and we've activated advocates through social media. Here's a list of some of our 29 patient advocacy partners. These are patient-facing organizations from across the country. As you can see, you'll probably recognize many of these groups. These are strong groups serving really a diverse range of cancer populations. And although we have mostly cancer organizations, we welcome any cardiology and neurology groups as well, because extravasations can affect anyone with any disease getting a nuclear medicine scan. Collectively, these 29 patient advocacies have been a force over the last year, trying to convince the NRC to correct their incorrect policy. So what can you do? Some of you on the line today are individuals, your healthcare providers, your patients. You may not be an organization. So here's how you can help. If you are an organization and are not yet a member of the coalition, join us. You can go to our website at safernuclearmedicine.org. You will find all sorts of articles, published papers, resources, other experts saying the same thing that we're saying. You will also find resources that we created that you can share, that you can print off, you can take to your doctor's appointment. These are infographics that are easily downloadable from our website. And if you have a story to share, please share it with us. If Pam's story sounded familiar to you, then tell us about it. We want to hear from you. But until the NRC changes the current reporting requirements, It is important for patients and caregivers to self-advocate before, during, and after a nuclear medicine scan, just like Pam did. So the first thing, if you feel like something is different, or as Pam said, it just didn't feel right, ask for proof of the imaging that there is no extravasation. Request an image of the injection site be shared with you. If the institution hesitates to share, then ask them the following questions. What amount of radiation accidentally injected into my arm is bad for me? And how does that particular institution know what amount has been injected into my arm if they are not monitoring for extravasations? Two very simple questions to ask. And if you are receiving advanced nuclear medicine therapies and you are not imaged for 24 hours, be sure to ask that institution, how do they know if the therapy was delivered as prescribed and you had not been extravasated? So we encourage you, everyone on the line, become educated, which is the first step you did today by attending this webinar, and then advocate for yourself and join our efforts in telling the NRC to correct their incorrect policy established in 1980. So right now the NRC is reviewing our information correction request. They do not have a deadline of when to make their decision. They haven't told us when to expect a decision, but we're anticipating a decision soon. So if the NRC decides to make extravasations reportable, this is what we anticipate will happen. Institutions will have to start monitoring injections of nuclear medicine scans. Institutions that routinely extravasate will be held accountable and need to improve, just as Pam had mentioned with the mammogram improvement. That will now have to happen for nuclear medicine scans. And keep in mind that estimated number of 500,000 patients every year not being told that they've been extravasated. That will change if the NRC decides to make extravasations reportable. Right now, if you're extravasated, that extravasation that Pam experienced was not noted in her electronic medical record. If we have to start reporting extravasations, patients will be told, their healthcare providers will be told, the extravasation will be noted in their medical record. So if there is tissue damage further down the road, and that tissue damage can sometimes take years to develop, that will now be in that patient's medical record. So if that tissue damage does develop, that they will know what that's from and they can correct the course. Importantly, steps can be taken at the time of extravasation to reduce the radiation dose to the patient's tissue. Right now, they're not monitoring, so there are no steps to mitigate the harm. If they're required to monitor, steps will be taken and protocols will be put into place if a large extravasation happens. You can mitigate the harm of the radiation dose to the patient's tissue at the time of the extravasation. Extravasations can be prevented with proper training and tools. We can prevent these. And as Pam mentioned, if extravasations become reportable, patients now have everything they need to make an informed decision on their care. They can look at extravasation rates of institutions around them and decide where they want to get their care. Do they want to go to an institution that has a large extravasation rate? Giving patients this information is not a lot to ask. This is a very simple request. Giving patients and their healthcare team the information they need to ensure their safety and accountability. So in summary, this is what we discussed today. 90% of PET and CT nuclear medicine procedures are used for diagnosis and treatment in oncology care. It is estimated that extravasations occur about 15% of the time, harming approximately 500,000 patients annually. These are large extravasations. Large extravasations can pose harmful effects to tissue, including tissue necrosis. Large extravasations can lead to inaccurate staging, missed disease results, and improper treatment. Today, extravasations do not have to be reported to the patient, to the healthcare team, or in their medical records. And this is because the NRC decided in 1980 that extravasations do not have to be reported. The Patients for Safer Nuclear Medicine Coalition is advocating for transparency in reporting to ensure patient safety. The NRC will decide soon if extravasations should become reportable. Until then, education and self-advocacy is key to preventing extravasation. You can learn more about our coalition at safernuclearmedicine.org. You can follow us on Twitter at safernuclear, or you can view Pam and other videos on our YouTube channel. Thank you so much for joining us today. I will now stop recording and we can take some questions. Feel free